welcome to you all, and especially Leena and Orkan, the floor is yours.
Thank you very much. So Orkan, will you share the screen, please?
Yes. Okay, does everybody see the screen?
Yes.
Yes.
Great.
Yes, so thank you very much and for the invitation to have this second keynote as well. And during this keynote, Orkan and I will provide some insights about research, practice and policy in the field of health literacy. And if you show the next slide, Orkan, you can see the structure and the content for this keynote. So in the first part of the presentation, I will describe some HBSC findings on adolescents' health literacy, which will follow Orkan's discussion on policy and school practice. And then at the end of the presentation, we will have a room for questions and answers. So the next slide, please. Yes, so health behavior in school-aged children study, that is HBSC study, is a WHO collaborative cross-national survey that is conducted every 4 years now in 15 countries and regions across Europe and North America. And last data collection took place in 2017 and 18, and the next one will be on 2021 and 22. And the target population group are the school-aged children aged 11, 13, and 15 years old. So the first time when health literacy was measured, it was as part of the Finnish national survey in 2014, and data was carried out among 13 and 15 years old. And the total sample size was somewhere around 3,700 adolescents. But in 2017 and 18, health literacy instrument was introduced as an optional package for countries to choose. And today I will present some findings using both our national data, but also data from 10 European countries, where the sample size was then close to the 30,000 adolescents in total. But just before we go into the findings, it's important to say that in HBSC survey, health literacy has been measured as a subjective construct, that is with a set of items that measure perceived competencies in health issues. And the instrument called Health Literacy for School-aged Children consists from 10 items. And we have 2 items per each 5 health literacy components that are theoretical knowledge, and we have an item such as that measure abilities to give examples that promote health. We have practical health skills, and items is like abilities to follow the instructions given by the healthcare personnel. We measure critical thinking, such as abilities to evaluate the correctness of the health information, and we measure as well as self-awareness, like abilities to reflect the reasons for personal health choices, and finally citizenship, such as abilities to participate in promoting health in close surroundings like schools and neighborhoods. And from these 10 items, we calculate a sum score, and based on the sum score, we dive it into 3 levels of health literacy: low, moderate, and high. So the instrument measures general health literacy, as it's not focused on any one particular health topic like nutrition or digital health literacy. And our intention was to develop a short measurement that could be integrated into longer surveys. That's why the length of the instrument had to be fairly short. So now I will go into some key findings from several national and comparative studies. And the next slide, please. Yeah, so we have found out doing the analysis of health literacy among 15 years old in Austria, Belgium, Czechia, England, Estonia, Finland, Germany, Macedonia, Poland, and Slovakia, we found out that there were quite fairly wide variations within and between the countries in the level of health literacy among adolescents. And regarding the 3 levels of health literacy, that is low, moderate, and high, in total 13% of the participants had low health literacy, 67 had moderate health literacy, and 20% reached a high level of health literacy. And the differences between the countries were statistically significant. And the proportion of low health literacy among the respondents varied from 6% in Macedonia to 17.7% in Czechia, and the proportions of high health literacy varied from 12.8% in Germany, around 38% in Macedonia and Finland. And the next slide, please. So in the same connection, we also checked about which kind of individual determinants or family level determinants explained variance in the adolescent health literacy level. And we have found that some of the findings were mixing, like the gender differences we noticed in some countries, but not in all. So like in 10-country comparison, gender was significantly associated with differences in health literacy level, that is, girls showing higher health literacy only in Estonia, Macedonia, and Poland, but not in other countries. And whereas several other studies, they have shown variations, the similar kind of variations in gender differences, and usually girls, if such statistical significant association can be found between health literacy and gender, usually girls are the ones who report higher levels of health literacy. But family affluence explains differences in health literacy level in all countries, with higher family affluence being associated with higher health literacy, which as well is in line with several other studies. Furthermore, if the sample consists of pupils of different age groups, the older pupils usually have shown higher health literacy level than younger ones, and that was also revealed in our 10-country Europe comparative study. We also noted that both academic achievement and having academic plans after secondary education are associated with higher health literacy levels. And for instance, in Finland, these two have traditionally been significant factors to explain health disparities among adolescents. And when taking into account the fact that health literacy is also linked to better health, these findings together raise the question if the children with poor school achievement and no academic plans and low health literacy are not only leaving behind schooling, but are also in greater risk of not reaching their fullest health potential. And finally, we have noticed that active participation to sports clubs is also linked with better health literacy, and especially among children with lower school achievement. And this led us to suggest that the sports club setting may work towards equalizing health literacy differences related to school achievement. But the critical point here is that, at least in Finland, high affluence among families promotes access to sports club activities. So if to benefit this probable beneficial context of sports club, then the club should ensure that access is available to as many adolescents as possible. And the next slide, please. Yeah, like we yesterday raised up as well, that health literacy has been recognized as a determinant of health, and we have been able to confirm positive associations between higher health literacy and better health outcomes. And the adolescents with higher health literacy appear to drink less alcohol and energy drinks and smoke less. They also report better sleeping habits measured with sleep length. They report better self-rated health, general life satisfaction and self-esteem, more physical activity measured with moderate to vigorous daily physical activity. less multiple health complaints, and that consist from different psychosomatic complaints, and lowered risk for problematic social media use. Also, other studies on adolescents have linked health literacy with overweight, quality of life, and general well-being, to mention some. So though causalities cannot be identified due to cross-sectional data that, for instance, HBSC offers, the findings shouldn't be overestimated. However, critical discussions are needed if health literacy can be seen as a critical or important determinant of health, as has been suggested, and especially how much variation in health differences should or even could health literacy explain. In 10-country comparison, we noticed that health literacy explained up to 7% of the variation in self-rated health, but more than gender or family affluence. And earlier, we have found out using Finnish national data that health literacy explained 10% of the variation and more than gender, family affluence, school achievement, educational orientation, or age, which all together with health literacy explained 12% of various health indicators, variance of differences in relation to different health indicators. And few other studies have shown similar findings or similar size range. But as, for instance, self-rated health is a robust predictor of mortality, it can be suggested that any factor that contributes to decrease in health disparities is important, including health literacy. Furthermore, if, for instance, adoption of protective behaviors to decrease the spread of the virus calls for abilities to find valid information and adapt the information to daily habits, we could argue that health literacy is a critical determinant of health as well. And as the timely access to healthcare services call for abilities to interpret the bodily symptoms and ability to navigate in healthcare systems, then we could also say that health literacy is a critical. And also, as the right to be heard and participate in the decisions that influence one's life expects that children should master those skills in order to be involved. And the next slide. With this slide, I wanted to describe more detail the association between health literacy and problematic social media use. And this is based on fairly recent research that is now under the review, and it's based on Finnish data. And just to describe more detail, perhaps first, that in Finland, close to 9% of 11, 13, and 15 years old can be called as problematic social media use, and that's close to European average, that is around 7.4%. And among Finnish adolescents, 34% can be called as moderate risk users. So we noticed that along with high parental monitoring, better health literacy was associated with lower prevalence of problematic social media use and moderate risk use. And no other background factor we examined showed the similar pattern. So it could be suggested that health literacy should be taken into account when developing interventions to decrease adolescents' problematic social media use, in addition to other unfavorable health outcomes presented earlier. But further research is needed on this one. In addition to look at general health literacy levels, it is important to look individual items, and I will give you an example of these ones. Next slide, please. Yes, so these findings show the proportion of adolescents who report difficulties in assessing the credibility of health information and comparing information gathered from different sources. Both of these competencies are crucial in times of extensive amount of knowledge that varies in its complexity and quality. And based on these findings, we could suggest that health education as an obligatory school subject in Finland has equipped Finnish pupils with slightly better competencies than in other countries we have focused on. However, to build such argument, we do need more research, but that could be suggested. And the next slide, please. Yes, so here we can see some findings on general citizenship skills, and I picked two extremes. I didn't show all the findings from all 10 countries, and findings on the item level give an understanding that is more detailed on health literacy competence levels and for formulation of the items for the aims for the health literacy interventions. So the final slide, please. Yes, so to sum up, I would say that the assessment of health literacy is important, as it kind of shows you some key factors that could be focused on or should be focused on when building health literacy interventions to promote health literacy levels among the adolescents. And according to the WHO European Roadmap for Implementation of Health Literacy Initiatives through the life course, population surveys provide opportunities for benchmarking, monitoring, and evaluation, as well as for increasing knowledge about specific challenges and opportunities, which can be used as data-informed starting points for the development of effective health literacy interventions. And now, Orkan, it's your turn. Orkan, you're muted.
You're muted.
Sorry, thanks. Thank you, Leena. I will now present some insights from our work here at the Interdisciplinary Center for Health Literacy Research, with a particular view on policy and how policy affects, in this case, policy research itself, and the practice level. In this order. And the first thing I want to show you are a couple of slides on available NGO policies. Here you can see World Health Organization NGO policies on health literacy. You can see that WHO has dedicated themselves to strengthen health literacy and to further promote it on all three levels: research, practice, and policy. And in the left bottom corner, you can see the rhinoceros on the cover, health literacy and health promotion. This is the document that was released during the Nairobi conference in 2009. And although health literacy has been part of WHO policies much earlier, this is the first standalone document that was published on health literacy. And in the top line, you can see the Shanghai Declaration from 2016, where WHO has defined 3 focus areas in relation to promoting the health promotion agenda in context of SDGs until 2030, one of which is health literacy, and in particular addresses health literacy in the context of schools, creating school curriculum and whole school approaches, also to increase equity and tackle health inequalities. And last but not least, what I want to show you are 2 documents. I hope you can see my cursor here. It is these 2 documents. These are the documents of the European roadmap of WHO European region to strengthen health literacy in the WHO region. Based on these, as we speak, an European action plan on health literacy is currently being developed. And this document here is also from WHO and the European Observatory. It's on investing health literacy, in particular in the education sector. So very important documents and policies by which WHO supports the development of health literacy in Europe and beyond. But it's not only the WHO, but I have also brought you some policy papers from the UN, the UNICEF, particularly addressing health literacy, the IUHPE, and also the OECD. And the 2 documents that I'm pointing now, the Future of Education and Skills, They define critical skills, attitudes, values, and knowledge areas to be addressed in school education. And one of the important dimensions mentioned there is also health literacy. And on the right-hand side, this document, health literacy for people-centered care, is not dedicated to children or education, but it's a general OECD policy on health literacy in the healthcare sector. So these were NGO policies, and I think it's also very interesting to look on available national policies. And here I brought you, there are much more, but I brought you some examples of national government-based health literacy strategies. For example, health strategies or national action plans on health literacy. Here, for example, this is our German National Action Plan on Health Literacy, which contains 15 dimensions. I will later talk a bit more about it. Here is the United States Action Plan on Health Literacy. This is the Australian. These two are from Scotland. You see the Canadian strategy and so forth. So you see that many countries understood that somehow health literacy is important, and in order to pursue health goals and health development in society, policies and government support is very, very important. But this does not mean that if there is an action plan, a policy, or government support, that there is really funding needed to conduct research, to implement programs, etc. But it's a good first step. If you want to read more about, in particular, European policies on health literacy, this is a WHO synthesis report. This is basically a review of all the existing policies in the WHO European region. Policies are also very important in context of education. And besides the policies that I presented to you on the national level, here are educational policies, also on the national level, that address health literacy in school curriculum. So there are not many. I brought those that I am aware of, that they exist. It is in the United States, first published in 1995, Achieving Health Literacy, and the 2007 update, Achieving Excellence. This is this one, and the new one builds up on the Achieving Health Literacy standards and further develops the standards. Then you have the Finnish curriculum. This is the curriculum for the whole education sector, and it has particular sections on health literacy for different grades, starting in primary school and continuing throughout secondary school until the end of the school. This is the Australian curriculum on health and physical education, and it is basically surrounded around health literacy. And this is the Portuguese curriculum on health promotion in school, and it has also health literacy attached to it. So back again, this is our German National Action Plan on Health Literacy. It's this one. And since 2018, we are conducting every other month or every third month, so fourth time or sometimes 5 or 6 times a year, workshops. And just last week, we did the 7th workshop, and the next month we will have the 8th workshop. And the first workshop that we did was on the first recommendation of our action plan. And this is to strengthen health literacy in the education system. It's this one here. And yeah, there are much more recommendations, 15 in total, and we do workshops for all of these together with stakeholders especially from policy, from the policy sector, who can help us implement the strategy. But the one for me that is important is this one. And the one that is being in December is also a school focus on health literacy in schools during the digital age. In Germany, the action plan is not the only strategy. We have also a particular health literacy strategy by our health ministry. And luckily, this also is addressing health literacy in children and adolescents in the education sector. This is the first of their action areas. And the third one is addressing, for example, teachers and their teacher training and education for them to equip them to be able to address health literacy in schools. And right before Corona, we had a big national conference in February, and lots of things were planned, but due to Corona for this year, at least they were shut down. And last but not least, this is the most powerful strategy on health literacy in my country, I believe, because this is a federal act. This is the Act on Health Promotion and Prevention, and it has in several of the laws and the legislations included here, health literacy in it, and all the time in relation to schools. So, and this practically enables many stakeholders across Germany, giving them funding to implement the health literacy goals. So this was just an overview on existing policies worldwide, policies in education, policies on the NGO level, and also policies from my country in Germany. Now I want to show you some slides from a project that I'm recently conducting in the Health Literacy in Childhood and Adolescence Research Consortium to further analyze these policies. The project is called PMO Plus, Policy Analysis and Health Literacy in Children and Adolescents, and it is based on a literature analysis in order to use information to do expert interviews and a good synthesis in order to get recommendations how to recognize, consider children and adolescents in these policies that I just shown you. And when it comes to policy, it is very similar like with health literacy. There are so many definitions on policy available, and everybody understands something different when he or she hears the word policy. But the definition that we use in this project is based on the book Making Health Policy by Buse et al. And they define policy in a very broad sense, and in particular in relation to health literacy, this is very important to do so. Decisions taken by those with responsibility for a particular policy area are policies. And they further define it a couple of years later. A policy is a broad statement of goals, objectives, and means that create the framework for activity. So, and this was the guiding definition that we used when we did a literature analysis to assess those policies that address health literacy in children and adolescents. And what you see here is a world map where I have highlighted all the countries where there are health literacy policies available, some of which I will later explain in detail are standalone policies, others are embedded in other health policies. The yellow ones and the green ones are those with policies available. The green ones are those where there are children's policies, and the yellow one are those where there are just general for the adult population. And the red ones are those where policies are being developed. In total, we could find 26 policies in 18 countries that have been published since 1995. The 1995 was the Health Education Standards Achieving Health Literacy in the United States, and the most recent one is Portugal. But in 2019, 2020, also in Norway, action plan was released on health literacy. I think Denmark is working on it, Israel is working on it, and Belgium is also working on it. But these are those that we could find. And when we look when we take a closer look to these policies, what kind of policies are these? There are laws, federal acts, like the one on health promotion and prevention that I showed you. The other one, there are only two, is the Healthcare Act by Barack Obama, which he released during his presidency in 2010, where health literacy is named. There are 13 standalone policies on health literacy, many of which are action plans, but there are also alliances or national strategies. But there are also general health policies that address health literacy, which I like most is the one in Wales, because this is the one on tackling inequalities and addressing health equity. And one important policy item in that document is health literacy. And there are the 4 school curricula on health literacy. So, and how do they address children and adolescents? And so this is a cross-cutting summary across all these policies. Most of the policies specifically have own sections or chapters or paragraphs on how to address children, and they all highlight schools and whole school approaches, addressing it in the classrooms. They also mention, when they don't mention children in particular, they mention that teachers' health literacy and their education needs to be addressed in order to equip them with the skill set, enabling them to address health literacy in the school, or by addressing the family in order to increase children's health literacy. So the direct way is one of the ways. The other way is the indirect way, where neither children, adolescents, or school students or pupils are mentioned, but the settings in which health literacy should be strengthened are mentioned. For example, kindergartens, preschools, schools in general, or the education sector. Can also be that they mention that in pediatric care, health literacy should be included in order to strengthen the health literacy of the child patients or the family, and also some of which some of the policies address organizational change, the organizational health literacy concept that I just introduced yesterday. So you see there are several ways. And when you do another analysis we did a strengths analysis, and here I'm only looking on the weaknesses. The problem of most of the policies, although they mention children and adolescents, is that they are truly meant to address health literacy in adults, and they have a healthcare focus. And when they address health literacy, they most often address the behavioral aspects to increase competencies, etc., but only few address the environment, structures, organization, etc. And of course, there are among these 26 policies, only 4 that are educational policies. And I think it is very important for the education ministries to collaborate with the health ministries to pursue health literacy. And what we also could find was that this kind of cross-ministerial collaboration is not very common. And also, although there are these policies, it is not clear how and to what degree they provide funding to support research, to support implementation on the practice level, etc. So there is much more room for improvement. Anyway, based on these results, we have, I will just skip this because I'm running out of time. Based on these results, we have developed a questionnaire to interview policymakers across the world. And we have interviewed policymakers in all these countries that I've highlighted in blue and in yellow. We talked in 46 countries with 63 policymakers or people who are involved in kind of health literacy policy making, with the aim. The interview guide was informed by the results that we gathered in the literature analysis, and the aim of this study was to derive recommendations how to better address health literacy in policies. And this is analysis work that we are currently doing. And now I'm reaching the last part of my presentation in relation to policy, and it's a view from policy to practice. And I've just introduced to you the curricula on health literacy from within the education sector, and they were truly meant to address health literacy. Many of them use the theme of health literacy, and what you see on the cover page is what you get. It's inside health literacy on the top and health literacy in the inside. We have nothing like that in Germany, no educational health literacy policy. But what we have since 2018 is the standards and the strategy for digital education and literacy in the 16 federal states. This was developed by the ministerial conferences where the 16 state education ministries sent their delegates to, and they together developed strategies for the education sector. And part of this strategy, where not only a strategy is defined, but also competence models for teachers and for school children are defined, was also a first package of 40 billion euro given to the schools in Germany, that they update their digital technology infrastructure. But this is not what I want to look at. I want to look on the competency model that is inside of this strategy. And it looks like this. So it is called the Media Literacy Framework, but this is only the name of these standards on the state level. On the national level, you know, we live on a federal system in Germany. On the federal level, this is the Digital Education and Literacy Standards. But on the state level, since media literacy is around in schools for more than 2 decades, they just used this term, but included the new content. And this is, you see here, 6 dimensions have been defined with several sub-dimensions. And the core health literacy dimension is this one, information competencies. You see the definition that I've shown to you yesterday: access, understand, appraise, and apply health information. So this is a mandatory curriculum for the schools and also mandatory for the universities to teach and train the future teachers. And it offers an opportunity, although it is not named, titled health literacy can be addressed through this. But this is not all, because when you keep the critical, functional, and interactive health literacy model in mind, with 3 of the other dimensions, it is possible to include health and address different dimensions of health literacy. And we have also seen in Leena's presentation how important health literacy is for social media. And of course, education is a holistic approach. And if we bring health literacy to schools, we must ensure that health literacy is at least embedded into this holistic approach and is inclusive to what's going on there. So there are further dimensions that are important to health literacy. For example, learning about use of social media, data protection, security, but also using IT in the times of big data and COVID-19. And for me, before this strategy was released in Germany, I was always thinking we need a standalone strategy for health literacy in the education sector. But now I think it is better to use what is available in schools already and which is mandatory for the schools to implement, and just to see how health literacy can be included there into this topic. Because you see, this is just the framework. This is not topic related. This is meant to be a cross-sectional framework that can be addressed in each subject. It's already in place. It is based on a holistic approach, mandatory on many levels. The resources are available for this. It is effective and it is sustainable. And I think that each of the countries in the world who don't have a health literacy educational policy, a curriculum, or whatsoever strategy for school, they can just go to their education ministry homepages, access the curricula, and just analyze them and see how health literacy can be included into all of this. I think this is a cost effective and easy hands-on strategy using the concepts that have been developed from within the education sector for the education sector, to teach children, to help them in their identity and self-development, in their socialization, etc. Sometimes this could be a more, I say, effective but also sustainable approach, because we make use of instructional methods, didactics, and content that is already in the education sector. Thank you. So this was the end of my presentation. I stop sharing my screen now.
Well, thank you both. That was really a lot of information. I was just thinking that I'm happy that we recorded this. So even though I'm here, so maybe the recording is not only for people that wasn't here, but so much information and so many things that we could dive more into. But so I think that we will really need to go back and look at that. And I'm so happy with the presentation here because we actually have a lot of policymakers in the room also. So a lot of this is really, I think, important information also, not only for research, but policymakers. So really thank you a lot. So the next bit is the questions, and I have given you, Leena, some questions in your chat, and Orkan, I will just share with you 3 questions. So while Leena is answering the questions, I will share in your chat 3 questions. So maybe you can just prepare a little bit while Leena is answering. Leena, do you need me to repeat the questions, or can you say the questions and then give your answers? Could that be a way to do it?
Yes.
Okay.
So Danit asked who determined the questions in the HBSC questionnaire. So all the questions are health literacy questions. So regarding, or perhaps health literacy questions. So we have in HBSC we have different focus groups and writing groups. And for instance, in health literacy we have a writing group, and so the writing group that I'm leading, we are pondering the questions that are used in the HBSC context. Danit, please comment if this was the question that you wanted to focus on, the health literacy.
Yeah, I wanted to know if she, as an organization, can affect the questions in the
survey.
Yeah.
I think this kind of interaction has started now, at least in Reykjavik, in HBSC. The HBSC meeting was held at the same time in the same place. So I think that more collaboration is happening now, and I think that in the SHE research groups there are several HBSC researchers as well. And definitely more interaction could be done, especially, for instance, related to school-level health literacy, school-level questionnaire that will be used more broadly in the following data rounds. Then Aris asked, yeah, you're welcome. Then Aris, you asked, when you say that health literacy determine health status or level, how do you measure that level of status? So in HBSC, we measure health using different kinds of health indicators. And for instance, self-rated health is one of the health indicators that we use to measure general health. But then we have these health behavior indicators that we kind of consider as some sort of health indicators. But I'm not sure, at least in self-reported surveys, they are based on these kind of self-rated or self-reported measures. And what is defined as problematic social media use? So in our HBSC survey, we use this scale called social media disorder scale that was developed by Van den Eyden and colleagues, and it includes 9 yes or no questions that focus on preoccupation, withdrawal, tolerance, reducing, stop, give up other activities, continue despite problems, and so on. And if and the pupil answers yes 6 times or more, then she or he will be kind of considered as a problematic social media user, and no risk for problematic social media use is if you respond 0 to 1, and then the moderate risk is in between of those 2. Alicia, you asked if there are HBSC questionnaires for plus 15 students. Not actually, but then I know that there are some countries who uses the questionnaires for the older age groups as well, but I'm not sure if they use this. Some countries collect data from the upper secondary education as well, but I'm not sure if they use the questionnaire for the 9th graders for that population or age group. Did I cover all the questions? I think I did. Jesper.
I think you did. I'm sorry, Orkan, if we did have a digital or technical. So Orkan only just received his questions like 20 seconds ago. So Orkan has had all but 10 seconds to prepare. But I don't know, Orkan, if you prefer for me to read out the questions or if
No, it's okay. I can read it. I think it's only one question, right?
There are. So maybe I don't know if there are technical issues, but just read out the question that you have, and I'll make sure that we.
Okay, I read the question. I see that Macedonia does not have health literacy policies. However, I think I remember that Macedonia adolescents had fairly high health literacy in comparison to some other countries. What do you think contributes to this? So this is the one question that I received, right?
Okay, I will send. There are two more. I don't know why they don't go through. They are on my screen. I will send two more, and
maybe you have to send them individually.
Yes.
But I can just provide an answer for that. I think if there is a health literacy policy or not is not necessarily determining the level of health literacy or the state of health literacy in the population. This is one thing. It can have an effect. It can also have a positive effect. And maybe there are other policies available, like the ones that I shown that, I don't know, support children and adolescents to support the necessary skills. On the other hand, Leena presented the questionnaire as a self-report measure. And most of the new comprehensive health literacy measures are measuring health literacy in this way. They ask you about how you perceive your own skills or difficulties in relation to predefined tasks. And then it's a subjective statement that you make. This is the way the self-report works, and opposite to performance-based. And it can be that children and adolescents rate their health literacy that high because they self-perceive the tasks to be easy. Maybe this is because they overestimate themselves. It can be that they are lacking the experience. Or it can also be that the whole system in which they are embedded and which provides the tasks or the information or the services, it is that user-friendly that really is easy. So this is the general shortfall of all these self-report tools. But it is it could be that it is. I just heard my.
Can I comment, Okan?
Leena, yes.
So yeah, that was a good point, that it's a subjective construct. Of course, it's the one side of the same story, subjective perception, and we know that subjective perceptions of one's competencies, they are important. It is an important predictor to behavior. But when we measured objectively learning in health education and health literacy using this kind of test-based assessment, we noticed that in general, Finnish adolescents succeeded only at the satisfactory level. So there is a difference between how they perceive their competence and how they actually are able to answer to these different kinds of questions, and how they're able to solve these problems that we created for them. So, and girls reached a good level, and boys actually quite low satisfactory level, but in the general it was a satisfactory.
Yeah, right. Before I move on to the other two questions, I just wanted to add another thing. We did a survey and are doing the second wave of that survey now in primary school-aged children, and where we use a self-report questionnaire. And based on this survey, the results show that almost 90% of the children between 8 and 11 years old have high levels of health literacy. So they rate their health literacy themselves. And of course, you can put these results in question, because I assume that children that young and even older adolescents, it is possible that they underestimate the tasks that they are presented with. And we can see that also in adults. Yeah, that adults, young adults in another survey that we did, 18, 19, 20 years old, they also do the same thing. They rate their health literacy very high. And when we do the presentation of the results on a scoring building level, like categories like limited, high, or medium health literacy, you end up with these numbers. But what you can do, this is what we have done in some of our data sets. We have only looked on the specific tasks, and the common theme across our own studies and studies by others is that tasks such as obtaining information, accessing or finding information, or just simple understanding is perceived very easy. But when it comes to making critical judgments about, I don't know, information in media, information in the internet, whatsoever, no matter if someone has a general high health literacy score or lower score, this specific task is almost difficult for half of the population measured in a survey, showing somehow pointing towards that this kind of critical thinking, critical literacy, making judgments, evaluating information is what a really difficult task is. Even if people think they have high levels of health literacy, in that, because it's all it's a calculation model, but in that model, there are still the items with the task, and these tasks might be difficult. But I can see now there are much more questions. It seems there is quite some policy on health literacy. Do you know if countries connect it to health promoting school, or do they see it as different topics? Yeah, in some of the countries, especially in policies in Asia or in the United States, they link it with health promoting school. In the United States, the health promoting schools, however, is not called health promoting school. It's called community something, CCCS. It's a different name, but it's basically the same thing, a whole school approach. But most of which don't do it, and they don't understand it's to be, or sometimes they don't understand it to be related only in these policies, not in general. And sometimes when we talk to the educationalists, to the practitioners here in Germany, and introduce health literacy, they often tell us we don't need that because we have the health promoting school, the German version, already in place. So we are already doing it, but it's a whole different thing.
There was a third question for you, Orkan. I don't know if you can find it, or you would like me to read it.
Yeah, can you read it, please?
Yes. It says, what about this research idea? That's not, okay, we'll take that in the end, actually, because we did get another question just a few minutes ago. When you look at the huge information that you just presented, would you say that there are mostly similarities between countries when it comes to policies, or rather than differences?
It depends. For example, here in Germany, we in particular used the Scottish, United States, and Australian action plans to develop the German action plan. And so there are some similarities. But in other countries, they have not used them. And so the action plans and strategies looked differently. And for example, in some countries, there is no health literacy policy at all, but they have health literacy in an educational policy. So you see, they all differ in some way, but many of those that are being developed right now, especially the one in Belgium and also the one in Israel, they used the existing policies to develop their own policies. They tried to address everything what was successful in these strategies and tried to update it. And from what I can see when I look into these drafts, I can see that education, the life course, children, adolescents, kindergartens, educational professionals, etc., other professionals working with children take a more important role in these policies? I don't know. I hope that answers your question.
I think it does. And then we did get both a question and a comment from Katarina, and who suggested that it could be an idea for the SHE research group for future years to review all of the national curricula related to health literacy and indicators, and maybe to get an overview of differences between countries. And I think so. This is also as much as a comment as a question. Some of you said in the chat that it was a good idea. So this could be, of course, be a suggestion for a working group in the SHE research group. I think it could make sense. And I think that's sort of, I don't know if Leena or Okan, you are of course free to comment on that also, but if we have time for one last question, I think, if someone has a last question, and if or can you
can I make a comment, because
yes,
there's a good comment from Katarina Wirnitzer. She writes, if health knowledge and health literacy would nicely match, we'd have no gap and even would have much better public health status. I partly agree with that, because the individual competencies and the knowledge are very important. But we know from the past 30, 40 years of research in public health and in medicine that a lot of individual behavior and the execution, the application of competencies is determined by the environmental factors. Where do you come from? What's your family home? What's your postal code? Educational status, etc., etc. Living environment, is there lots of nature, or do you live in a rather central place with only few spots with nature and good environment, etc. And I think these things have to be addressed as well. So it's not sufficient to only address health literacy. It needs to be understood holistically. All the other things must be addressed as well, and maybe together, then we can accomplish better health outcomes. And in one of the slides that Leena presented yesterday, she highlighted on the section on ethics and social justice, the targeted approach, using the proportionate universalism principles, doing things that are for all, but proportionally designed to meet the level of disadvantage of, in particular, vulnerable groups. And this also includes, or particularly includes, interventions on the policy level, because we see it in COVID now. Knowing about how to behave and having the competencies is one thing, but being exposed to the living conditions and the things that you need to do is sometimes much stronger. And I've not talked about the attitudes and other things that come in play, but I think it's important to understand this holistically, not only health literacy or knowledge, but also the rest.
Thank you.
Yes, I would like to add to this Orkan's comment and go back to one of the slides, or in the what I said in the context of one of the slides was that we have got the findings that the health literacy explained 10% of the variance of the health behavior. So there is 90% something else. And that's basically, I think when we looked about similar findings of the previous studies, the figures are quite the same size. Among adult population, perhaps a bit more, but especially among the adolescents, they are not that high. So that kind of tells us that the health behaviors and health, they are complex phenomena, and there are different things influencing on those.
Thank you, Leena and Orkan. I think we will close this session here. We have had a really, really good presentation, so much information, and I really need to go back, and there was lots of stuff we can dive into, I think. And I think we have answered most of the questions that were in the chat. So thank you so much, Leena and Orkan, for your energy and your time. And so I will post the link for the evaluation. So all of you that are in the SHE Academy, please also answer and then stay in this room. And if you are not a part of the SHE Academy, please answer the evaluation, and then you can log off and you can go to the SHE website. And if you need to see the presentation from yesterday, and soon we will, within the next couple of days, we will have this presentation there as well. So yeah, thank you all for joining and for your participation. I think we will just give everybody an opportunity to answer the evaluation. And those of you who are in the Academy, you see that Caroline has just shared the links that we need for the next session. So Leena's group will just stay on this link, because that's the same link that is in the chat now. So we can just stay on this link here. And I know that Julia's group finished this morning because there was a person that is not in the group or was not able to join today. So just give yourself time to.
Jesper,
yes.
Do you want us to share the links to the group rooms, to the breakout sessions, or?
Caroline just did that in the chat a little bit further up. So many people have asked thank you, so maybe it disappeared in the chat.
Okay.
But if you just scroll a little bit up, so when you have finished, yeah, Orkan and Caroline, I guess you can, if you log off here and start up your groups, the participants of those groups can log in, and we have a break until 2:30. So I mean, so the work doesn't start until 2:30, but we can start up the groups now, and people can just turn off the cameras and sound.
Right. So I will start the room. I'll see you later. Bye bye.
Yeah, see you. And
Bye,
the people
thank you.
that in Leena's group, you can just stay here. You can, turn off your sound and cameras and take a little break for 15-20 minutes, and we'll meet up here again.
Jesper, will you finish the recording? I don't think
I
that
did
our group wants to have to be recorded.
I did it again. I did